Well, hello, everybody, and welcome to this episode of the podcast show. My very special guest is Denis Thompson. Denis, welcome. And
Thank
introduce
you,
yourself.
sir. Appreciate it very much.
Okay, tell us a little bit about yourself. Where did you start? What's your role in this chronic pain world?
Well, I'm the CEO and the founder of a technology and a therapy called neurotherapy. And neurotherapy basically started about 25 years ago. And neurotherapy works on why you have pain, not where you have pain. Over the past 20 years, we've treated well in excess of 500,000 people all over the world. We've been in what I call, Wayne, the classes business, not the masses business. If you could afford us, we worked with you. So we've worked with probably the most elite athletes in the world and some of the highest paid executives in the world as far as clientele. Our goal this year is to get into the masses, not just the classes. So we're introducing a variety of new technologies and programs and products. And that's why we're here.
Okay, so let's tell us. I know you have a history in learning in exercise physiology, so you understand the physiology, but what was the thing that made you change from that approach and then go into sort of study pain and why are people having this problem?
Well, I think I mean, not to be facetious or anything, but as I was telling you earlier, when I was in school, I asked my professor, why do we have atrophy? And he couldn't answer the question. Now, I'm a why person, not a where person. So I'm always asking, why do we have that problem? Why do we have pain? Why do we have atrophy? Why do we have injury? And the answer is not physical by any stretch of the imagination. So I couldn't put it in my own little box of knowledge. So I had to go out and look for a new box of knowledge. And what else is there? There's neurology. Unfortunately, neurology isn't taught in medical school, physical therapy school, et cetera, et cetera. So I became self-taught in what is now termed neuroplasticity. So I was working with communicating from the lower motor neurons to the upper motor neurons before telemedicine was even a word. So that's really how it started, is I couldn't answer simple questions. And to this day, most medical providers can't answer those questions. We have a double-blind study answering those questions. And that answer is neurology.
What was the study?
Exercise physiology was my primary focus in school. But I became very disenchanted because, like I said, I couldn't answer simple questions. So I began looking outside of the box, so to speak. So I looked at mentors. My two main mentors, one was Yakov Katz. Dr. Katz was the first neurophysiologist, keyword neurophysiologist, in Russia in the 50s, 60s, and 70s. He was in charge of the Federation of Russian Athletics. That means all of the Olympic athletics. Now, if you look at the 50s, 60s, and 70s and look at what Russia did to us, a gigantic country as opposed to a small country, you'll understand how Katz thought. My other mentor was a doctor by the name of Bjorn Nordenstrom. Nordenstrom was the director of the Karolinska Institute in Sweden, Nobel Peace Prize winner, and the inventor and developer of the needle biopsy, who wrote a book called Closed Bioelectrical Circuits, and that triggered everything that I do. So I believe that the human being is a neurological or an electrical mechanism like a computer, and every computer has two components, hardware and software. Most doctors are trained in the hardware. They are not trained in the software. So up until about, what would you say, Wayne, 20 years ago, we all believed that the brain was hardwired. It couldn't be changed. Well, it definitely can be changed. It's a software program. So you just change the software, reinstall new software, and you broke a pattern. So when you talk about pain, pain to me is a neural pattern, period. So your brain is saying, I have pain. So you're in a sympathetic dominant state. You're in fight or flight all the time. Muscles are in concentric contraction. And all I do is change that pattern where you don't need drugs. You don't need anything other than a new neural pattern. And it's incredibly successful.
Okay, so you're changing it from the sympathetic to the parasympathetic. Is that right?
Immediately. The key to everything that I do is bring a patient out of sympathetic into parasympathetic, because if you're not in parasympathetic, you're not going to heal very quickly at all. We all know that. But the trouble is we try to medicate it and we try to do therapy. Therapy of any kind is not going to move you out of sympathetic dominance because it is a neural pattern. So therefore, you have to disrupt the present neural pattern to put you in a completely different pattern. And if you look at all disease, injury, post-surgical activity, et cetera, everybody's stuck in sympathetic dominance.
Mm. Yeah, with our busy world and our crazy world that we live in, you know, it's impossible, I think, to be in a persistent parasympathetic mode. It's just like, how do you do it?
Unless you train yourself to be that way. So exactly. If you train, again, it's software. You can train that software and you are what you repetitively do.
Yes.
So when I first started working with CRPS patients, one of the things that I noticed is, you know, they would either be on ketamine, they'd be on all sorts of different medications, but it didn't change their movement pattern. So I said to myself, wait a minute. If the movement pattern is consistent, their pattern is consistent. So the brain is picking up on the fact, excuse me, that they're in this pattern. So if I medicate it, all I'm doing is getting rid of the pain, hiding it, but I'm still in the same pattern. So I believe you have to change the pattern. You have to change the way you move. You have to change the way you think. And you have to change the way you activate around others. All of that is a neural pattern. One without the other does not resolve the problem.
Exactly. Exactly. We need to retrain. So tell us about your therapy. How do you go about getting this shift from A to B?
Well, first off, you have to understand that neural patterns are an electrical pattern. Everything in the body is an electrical pattern. So I use an electrical current, which is bioharmonious with the body. So if you do an EMG and you see the wave, you know right away that the body has a wave in it. So what I did is I said, okay, why don't all these other electrical devices change you from sympathetic to parasympathetic? Why do they keep you in sympathetic? Well, the answer is real simple. They're foreign to the body. And anything foreign to the body is immediately going to react to protect. Well, what is protection? Fight or flight, better known in our world as sympathetic dominance. So if I'm trying to work on somebody and keep them in sympathetic dominance, it doesn't make a great deal of sense. Again, I'm a why person, and I kept asking the question, why do we have the same result? Well, the answer is that we're keeping them over here in this little box, and we're not moving them into another box. So I figured out a way to trick the brain with an electrical current that doesn't send the alarm signals. And if it doesn't send the alarm signals, guess what the opposite side of that is? Parasympathetic. So then I had to demonstrate to a patient that they could do something that they normally couldn't do. So let's take somebody like a frozen shoulder, which I don't believe there is such a thing, but let's just use the example because it is a current medical terminology, frozen shoulder, adhesive capsulitis. What is it? Why is it frozen shoulder? Well, what do we do? What does the surgeon do? A surgeon puts you under, grabs a hold of your arm, and moves it anywhere they want to move it. Now, if it was anatomical, they could not do that in a million years. So I take you out, you come out from underneath the anesthesia, and I can't move your arm anymore. Why? Because it hurts. And if it hurts, you're not going to move. So the first thing in pain is demonstrate movement doesn't hurt. How do you do that? You trick the brain into believing that it doesn't hurt. How do you do that? You take the muscle out of concentric contraction, allow it to go to eccentric contraction, and the second that happens, the muscle lengthens, taking the pressure off of the nerve, and the pain drops instantly and range of motion changes. And the patient says, oh my goodness, I haven't been able to do that for years. That is what I need to hear. I have to have a positive cognitive reinforcement of a change, or there is no change. You as a physician, I as a physiologist, we can see all sorts of changes. But if we don't hear it coming back from that patient, there is no change. So the first thing in our therapy is, and I believe the missing link in all of therapy, is communication. So if I were to take every single one of your listeners and give them a very simple neurological test that we developed, 95% to 98% are going to fail the test, which means that a simple analogy is if I came over to your house today, went into the garage, turned the main power in your house off, you're not going to be that successful at turning lights on. So I believe the reason therapy takes so long, and medication for sure takes so long, and of course the drug companies want it to take long because that's how they make money, is because we're not a neurologically efficient society. We're physiologically efficient, but we're definitely not neurologically efficient. What I mean by that is there's no direct communication from lower motor neurons to upper motor neurons. Now, all your colleagues work in the upper motor neurons. I work in the lower motor to get them to communicate to the upper motor neurons through what's called the alpha gamma loop. And if that alpha gamma loop isn't complete, you're going to fail my simple neurological test. So then what I have to do in our therapy is, because I can't deal too well with the lights off and I can't deal too well with the power off, I got to turn the power back on. So I figured out a way. It took me about 10 or 15 years to figure it out, but I figured out that the very first pattern we as human beings learn how to do is how to crawl. That's the first neuro pattern we ever learn how to do. Left side controls right, right side controls left. That's how we crawl. Well, I need to reestablish that software. So what I do is I put an electrode on the specific area that I'm trying to do this with. We're not going to give the private secrets out, but so I'm communicating left to right, right to left. So the electrode communication is going like this. So I'm telling the brain at roughly 500 times a second that your muscles are working correctly, and your brain is telling them at 2 times a second they're not. I'm going to win that race every single time. So it takes 3 minutes to reestablish that neurocommunication, and then we retest to determine if it's stuck. We can reset the lower body, the upper body, and the shoulders. That's everything that there is. Now, once we do that, now I got to find out, where's the pain coming from? Because it has nothing to do with where you feel the pain. So if you have medial epicondylitis, as you know, every doctor is going to work on your elbow, either on the medial side or the lateral side. It has absolutely nothing to do with where the pain's coming from. So what I do is I take an electrode and I created a diagnostic method. Now, you as a medical provider, you have MRI, X-ray, ultrasound, scans. That's about it. And they all tell you the same thing, where the problem is and the severity of the problem. Doesn't tell you one thing about why the problem's there. So I scan the body with an electrode and I'm looking for an electrical short. Well, what is an electrical short? Sodium, potassium leakage. Wherever I find sodium, potassium leakage, I know there's no cell communication. I know there's no neurocommunication. Consequently, that's problematic. So then I anchor that electrode at that location. Now I've got the beginning of the signal. So let's say it's medial epicondylitis and I have that electrode anchored on your left iliopsoas. You hear what I said?
Yeah.
Medial epicondylitis,
Yeah.
left iliopsoas. By the way, that's some of the treatments we've done. The red electrode, which is the end of the signal, I now have to scan the body and find out where the end of that signal is. The second I find the end of that signal, we then begin treatment, and we do it bilaterally because the non-involved side needs to train the involved side on how to work efficiently. Because if you miss and don't do the non-involved side,
Not gonna work.
you're not going to solve the problem at all. So now we're working bilaterally and we're working cross signals and we're overriding the brain. Again, the brain communicates at 2 times a second. An external brain communicates at 500 times a second. So every one of your listeners who are in pain, their brain's telling them at 2 times a second they're in pain, and I'm going to tell them at 500 times a second they're not. I'm going to win. And then I have to completely reestablish that new neurocommunication, and it starts with movement. So I have them do a movement that normally bothers them. So let's say they have CRPS in the back and they can't get out of a chair without pain. Well, I guarantee you the first thing they'll do when they come out of that chair is their upper torso is going to go forward, knees are going to go forward to the ankles, and then they're going to try to stand up, and it's going to be difficult. Well, Physics 101 says if you bend forward, force curve is going to be at the base of that bend, and the knee going above the toes is going to place the pressure right on the patella or the patella tendon. So typically they're going to have knee issues and back issues. What I do is I get them to stand up like this and they have absolutely no pain. Now they're not capable of doing that without assistance because they've not been in that pattern. So what I'm now doing is transferring the force curve out of the tissue that's being constantly irritated by incorrect movement and reassigning that signal to a muscle to do what it's supposed to do. And now consequently, we're well on the way of establishing a new pattern. And that patient is going to get up out of a chair without pain. It's not magic. All I did is just took the pressure off the back, transferred the force curve back to the muscles it should have gone to begin with. And that, unfortunately, is not a physical phenomenon. It's purely neurological. Then once we do that, once I get you moving, I explain to you, and you would find it fascinating, Wayne, and what we should do is that we should do this on one of your patients, but you would find it absolutely fascinating because that patient's going to say to you, I haven't done this for 10, 15, or 20 years without pain. And I tell them after their first treatment, look, we've done nothing but disrupt your pattern. It's going to be disrupted for roughly 15 to 45 minutes. And it's going to come right back. And here's why you absolutely 100% have to go through 20 treatments is because every day we disrupt that pattern for a longer period of time. So day 1 might be 45 minutes, day 2 is an hour and a half, day 3 is 2 hours, day 4 is 4 hours, et cetera, et cetera. When I get 20 sessions in, unless they're sitting in a chronic situation that they've had for years and years and years, like CRPS or fibromyalgia or whatever, they need a whole lot more reinforcement. But for the typical pain patient, 20 sessions, they have a brand new pattern. They'll never even know they had pain. especially if it's musculoskeletal. If it's CRPS, which, like I said earlier, we've treated probably 50,000 CRPS patients, taking them completely off medication. I tell every single one of those patients at the beginning of their first session, you got two choices. You're going to be addicted to drugs for the rest of your life, or you're going to be addicted to this technology for the rest of your life. The difference is drugs eventually are going to kill you. They're going to rob you of your cognitive ability. They're going to rob you of your mobility, and your quality of life is virtually non-existent. This technology is going to increase your cognitive ability, increase your mobility, give you a quality of life that you would never have, and be a fraction of the cost of what drugs are for the rest of your life. Those are your two choices. But if it's musculoskeletal or if it's post-surgical, 20 sessions and we're have a new pattern.
Wow.
Yeah, and it sounds way too good to be true.
Yeah.
So what I'd love to do is basically, I'll send you one of our pieces of equipment.
Sure.
You and I will work with one of your patients.
Sure.
I don't care who it is. And I'll be the therapist. I've got therapists all over the world, but I'll be the therapist. I'll walk you step by step through the process, and you'll see instantaneously what I'm saying is accurate.
I'll take you up on the offer.
Oh yeah, it's so much fun because you're now able to change the quality of life of almost every single person that you're treating, but more importantly, you're able to find out where to treat them, not why you've been treating them in the same location with medication or whatever. It's a very simplistic way, but very complex.
I just want to go over the technical side of it because I think I've got it, but I need to clarify. So if you've got a sore elbow, we'll keep it simple, and that's like where the pain is, and then you do your scan with your electrodes and you pick up this dissociation between the sodium and potassium. That's what's going on electrically inside the cell, which is in every cell. There's always potassium and sodium ions. So there's a disconnect there. So you pick up that bad signal, and it could be anywhere in the body.
Anywhere.
And then you go to the automatic opposite side.
No, I go and then I scan with, I got a negative electrode on one, so now I got to scan with the positive electrode to find out where the end of that signal is.
Okay, got it.
Once I find the end of that signal, I now have complete communication, beginning and end.
Right.
It's going to be nowhere near the elbow.
So the elbow could be the presenting problem. You may find it's the middle left back is the negative electrode, and the positive one could be anywhere, like the right foot. Doesn't matter, right?
Anywhere.
And then you've got that connection between positive and negative, and that's where you send the signal at 500 times a second to connect. So you're overriding the brain's idea that your elbow is the problem.
Yep.
And all of a sudden, things start to change electrically.
Yeah, think of it like a railroad track. Your brain is, let's say it's a 2-inch railroad track, right? And that 2-inch railroad track is saying, I have pain. And then I start creating a brand new railroad track. And when it gets to be 2 inches wide, now we're equal. And then all of a sudden I get to be 3 inches wide. There is no 2 inches wide on your side. That is called neuroplasticity. And that's exactly what I do. And people say, well, my elbow hurts. Why are you treating my glute? Well, I use a very simple analogy because I love analogies because patients understand them very effectively. I said, look, if you're a television set and you have a short in the TV, does the TV work? The answer is no. Does it make any difference where the short is? No. The body's the same way. Unfortunately, we don't look at it that way. So Nordstrom in his book had a phenomenal statement. Now, this book is about 4 inches thick, and he did the exact opposite of what your colleagues did. He upset the entire medical community by doing it. Instead of publishing thousands and thousands of papers, he said, no, 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 no. I'm going to write a book and compile all of this data. So, you know, when you read this book, it's so far above the spectrum of knowledge of most of the educators out there that it just ended up sitting on a shelf. But when I read it, the thing that resonated to me the loudest is this statement: every injury and every disease creates a bioelectrical disturbance. And Wayne, here's how he found that out. This guy's a world-renowned radiologist. He's looked at hundreds of thousands of radiographs, right? So one day he's sitting in Sweden and he's looking at this radiograph and it's got a halo around it. And he said to himself, wait a minute. Is this the first time I've ever seen this halo? Or is it the first time I've ever recognized I see this halo? So he went back and he started looking at graphs a year earlier, 2 years earlier, 3 years earlier. Amazing. Every single one of them had a halo around the cancerous cell. He then said to himself, how in the world did I miss this all these years? And the answer was, I wasn't looking for it. It just popped up. So then what he did is he put an electrode, because he knew if there's a halo, it certainly isn't cellular. It had to be something else, right? So it was an electrical disruption, which is completely unfounded in their knowledge base. And he put an electrode in the cell and put another electrode distal from it. And guess what happened to the halo? It started to dissipate. And if you go on Google and you read about Bjorn Nordenstrom, Tim Johnson on 2020 interviewed him, where he had gone off and worked with cancer patients and had a unbelievably successful scientific research program with what they called at that time throwaway cancer patients and post-surgical pain or post-cancer pain, post-chemo pain. So it's all about electricity. And if we can change that electrical communication, we can change the physical appearance of the problem. Does that make any sense?
Yeah, it does. I'm very aware of the electromagnetics of the body. And, you know, as I've done my research over the years as well, and I integrate, you know, the basic principles into explaining why things happen. But I love the work that you've done and taken that initial question about atrophy, which is just, you know, wasting away of a muscle group. And then from there, developed this technique that's revolutionizing people's treatments. And I'm thrilled that you're able to, you know, change the course of your direction to make it applicable to the masses, because we need to have a new system. As Buckminster Fuller says, you know, you want to change the system, you got to be the system. You got to create your own system.
You have to create your own, because you know, the age-old expression, you know, you're a pioneer, you got arrows in your back. You know, I can't tell you how many medical conferences I've been thrown out of. I mean, I was at Cleveland Clinic not too long ago. We were in a conference. They had heard me at a pain association meeting. And I basically said in the pain association meeting, I said, what if the way we look at pain is upside down? What if instead of a overexcitation of the nerve, it's exactly the opposite? It's an underexcitation. And every medication that's on the market today is designed to ramp down the excitation. What is the net result if I'm right? You know, by the way, I believe I am at 50,000 cases. Every patient we treat, we overexcite. So I believe CRPS, fibromyalgia, et cetera, are not overexcited nerves. I believe they're understimulated, oversensitive. And that oversensitive comes because they've entrained, not ingrained, entrained a neural pattern of pain. And it just keeps getting worse and worse and worse, because the more they do the same thing over and over again, it consistently reinforces the problem. So in our effort to get to the masses, we came up with a portable device that we're pioneering now with a variety of patients, CRPS, primarily neuropathy, where it eliminates the need for medication. It's not a treatment. So if you have someone with neuropathy pain or someone with CRPS, again, that's a feeling, that's a pattern. So how do you get rid of it? Well, you can either medicate it or treat it or whatever. So this device overrides the signal. Again, remember I said your brain's sending it at 2 times a second. This device sends a current in a very low current at 245 times a second. And let's say you have neuropathy. All you do is tell me, okay, I have pain in the bottom of my foot. All right, well, put this electrode on the bottom of your foot, put this other electrode on the top of your foot, hit this little plus button until you don't feel that pain, until you only feel that electrical sensation. You don't feel pain anymore. You don't feel numbness anymore. You don't feel pins and needles anymore. So what we're doing is we're offering to give anybody in pain, I don't care where they're at in the United States, we'll send them absolutely at no cost for 30-day use of this device. And this device is designed to get them off of medication. It's a tool to get them off of medication. It is not a tool like we were talking about earlier that I'd like to show you how to, how we can treat your patients. It's not a tool for treating. It's a tool to eliminate the need for medication. Because what is medication? It's an instant abort of the signal, or it's an instant prophylactic. I mean, that's why we take medication. It's either abortive or prophylactic. That's what this tool does. So if they have pain, they just hit that button. They can keep it on all day long. They can sleep all night long with it. And they're not going to feel the pain. They're going to feel another sensation. Now, you and I have been taught, and every single listener listening has heard this 1,000 times, but we've never applied it to medicine. And that is, if you've got a screaming headache and it's a 10 on a pain of 1 to 10, and I say to you, Wayne, do me a favor, put your hand on that table. I'm going to hit your hand as hard as I can with a hammer. You don't have pain anymore in your head. You got a hand pain. Why? Because that hand pain now is the most current thing yelling the loudest to your brain. What happened to your headache? It was overridden by another sensation. So again, being a why person, I said, wait a minute. Why don't we do that? Why don't we just override it, not mask it, not block it? Because when you block something, you're blocking the entire signal. You're getting no re-education. You're not getting any prophylactic activity at all. Why not just give them something else to think about? And most people in pain would rather think about something that's a whole lot more pleasant than pain, which is just simply a feeling of tingle, tingle, tingle. Not numbness, not pins and needles. So anybody that's listening through your show, and we'll cross market, I'll send them absolutely free that device to use for 30 days. And they'll be the judge if it can help them or not. That is how we intend to get into the masses.
Listen, thank you for that. I really appreciate it. It's awesome. And yeah, let's connect up again, and let's try your treatment on one of my patients. That would be fantastic.
I'll send you a email with a link, and then that'll get the equipment coming your way, and then we'll set up a time. We can do a Zoom call with a patient on a HIPAA compliant Zoom call or whatever.
Yeah.
And we'll show you how the process works.
Cool. Well, listen, thank you so much. Been awesome to talk to you, Dennis, and congratulations for what you're doing in this world, helping people with pain and changing it from the brain out and from the electricity out into reality for people. So
correct. And what I'll do, Wayne, is I'll send you a link that you can put on the bottom of your podcast for everybody to respond to if they would like to try it for 30 days.
Well, let's keep this ball rolling. Thanks so
Very
much.
good. Thanks, sir. Have a
Take
great
care.
day. Bye-bye.